She's going to moderate the session on a case-based discussion for oncology patients. And to join in as a panelist, may I invite Dr. M.V. Chandrakant, Dr. Arnav Bhattacharya, Dr. Sani Khanna, and Dr. Bayo, please.
Your son?
Yes, ma'am.
Dr. Sun. And Dr. Bayo, where did he go?
Yeah, she can, yes, yeah.
Yes, left on emergency. Yes, left on emergency.
Oh, he left. Okay, fine. No, because I had questions ready. Can I just have my slide? I had questions ready for everybody. That's fine. So we don't have Dr. Harsh or Dr. Next slide. Oh, just here. Oh, correct.
Right.
Okay, yeah. So just before we, just a very quick the introduction. So malnutrition is very common in patients with cancer. Up to 80% of patients with cancer are reported to have malnutrition. And 20% of these die because of malnutrition itself and not because of the cancer per se. The negative outcomes associated with cancer, malnutrition in cancer, which is called as cancer cachexia, includes high cost, longer hospital stay, higher infection rates, reduced quality of life, poor functional status, and longer recovery times. So in cancer patients, as we know, the malnutrition is not only because of the disease process, but also because of the treatment related to the disease and the different types of treatment. So side effects include anorexia, early satiety, fatigue, depression, pain, nausea, mucositis, malabsorption, taste changes, and all of these can lead to decreased oral intake. So coming to our case. So 55-year-old male patient who presenting features of abdominal distension, loss of weight and loss of appetite for the last 1 month. Investigated, labs revealed hemoglobin of 9, protein of 5.5, albumin 3.1, normal liver and renal function, and a normal random blood sugar. The CACT abdomen showed diffuse thickening of the pylorus with enlarged lymph nodes. Biopsy showed adenocarcinoma of the stomach. The plan is neoadjuvant chemo followed by surgery. So my question goes to Dr. Sani. Would you be concerned about the nutritional status of this? Let's say this patient comes to you in your clinic and you send to your oncologist for neoadjuvant chemotherapy with a plan that you're going to do surgery after that's over. Would you be concerned about his nutritional status?
Yes, ma'am, definitely will be concerned. The gastric outlet obstruction will be concerning whether the patient is having one or not, I don't know. It looks locally advanced, say, stomach and abdominal distension, loss of weight and appetite. So abdominal distension may be due to gastric outlet obstruction. Loss of weight can also be due to anorexia because GI tumors usually patients have anorexia early satiety. And we can see that the patient tumor might be bleeding because he is having a hemoglobin of 9, so he is having anemia. He is having hypoproteinemia and hypoalbuminemia both. So protein intake is not adequate. He is having normal renal functions, that's fine. But before starting any form of cytotoxic therapies, I need to have a proper BMI of the patient. It should be between 80.
Which is not supplied here.
Yeah, not supplied here. We want that. And before starting any chemotherapy, we need to know all those things: body surface area, BMI, so all these things is required. So if the patient is not in gastric outlet obstruction and is able to take orally, then in such a case with a means maybe nearly normal weight or a slightly underweight, we think of K-POX.
So we will be discussing as we go by the approach. Absolutely right. Just with this, example, I was trying to set the scene and, introduce the concept of cancer cachexia, which everybody who's doing oncology and who's coming across oncology patients will be concerned about. So all these reasons that we stated, causing malabsorption, inflammation, anorexia, altered protein and fat, which most of the points that Sani has covered. So these are conditions called pre-cachexia, which can lead to cachexia with time and therapy and the progression of the disease process leading to weight loss, muscle wasting, and fat breakdown. So that's cachexia. So the definition of cachexia, sorry, my bad. Yeah, the definition of cachexia up there is it's a multifactorial, most phagocytic syndrome characterized by continuous decline in skeletal muscle mass with or without loss of fat. And the diagnostic criteria are weight loss more than 5% in the last 6 months. That's right there down on the slide. I don't think you can see it at the end of the room. Weight loss of greater than equal to 2%, and as he said, he needs a BMI. So with either a BMI of less than 20 or sarcopenia, that's loss of muscle mass. And this might lead to refractory cachexia and all the poor outcomes, also related to both to the disease as well as to the therapy. Right? So what we'll be covering very broadly, and you see the SPEN has a guideline on cancer patients. So I thought of following that. So the points, it's very clearly, it's very well written actually. So the points that we'll be covering is the general concepts and concepts related to the specific cancer patient categories. So we'll be dealing with screening and assessment of the entry and substrate requirements and whether we need nutritional bits. I'm just going to touch upon, and I just stopped him because we'll be dealing with that for the part of the rest of the panel discussion. And exercise, because we often feel that cancer patients should be advised that is it right, is it morally right to ask them to move about too much. Let's say if they can't tolerate that, so is it right to exercise that we'll be discussing? And additives like dietary additives like pharmaconutrients and some drugs for the GI tract. And the specific categories of patients, surgeons, we have surgeon here, we don't have a radiotherapist, so the question's going to go around. Medical oncologists we have, and medical oncology will include both curative and palliative cancer chemotherapy, as well as special groups with who require high dose or multiple doses of chemotherapy, and the hematopoietic stem cell transplantation patients. And then a bit about cancer, diet in cancer survivors and in the palliative settings. So Anirban, yeah, my question to you. You work in the ICU and you've been working in the ICU, and the ICU, if a patient is admitted, any of these patients might come, a med-onc patient, radiotherapy, post-surgery patient. So the ICU usually is looked upon as a one-stop solution for patients, and people will be coming and asking you, who do you think should be looking after? So this is my broad question to you. Who do you think should be looking after diet in these sort of patients?
And that is a very interesting and a very relevant question Sudakshina you have asked. I think that diet is one aspect which we ignore willfully or unknowingly, thinking that this is a component anybody can advise. Even if the ICU intensivist has not looked, resident says that surgeon has told, someone has told, okay, well, you continue. So rather than mentioning that this is something very important in which there can be either a collaborative discussion in which the input can be given by everyone, or collect input from everyone and let the dietitian. So till the time we have qualified dietitian, I think that intensivist person or by default the treating physician, after obtaining information, necessary inputs from everyone, can guide the therapy. But there should be someone.
Approach.
It is a multidisciplinary approach, as you have shown in this slide, that in each stage, and in each stage the role changes. As you have rightly shown that in the screening, we have to involve the nurse also, because their inputs,
the first point of contact.
absolutely, their role in assessment of the patient and determining that once we know that these patients are screened, then the assessment, there again the role of physicians will be larger. So it's a multidisciplinary team approach.
Right, thank you very much, Anubhav. That's just what I was also wanting to point out. It's the nurse, the doctor, the different types of doctors, all the different, just like you have a board, a medical board for a patient's plan of treatment, the cancer patient's plan of treatment, and the intensivist also if the patient is in the ICU. Right, and obviously the dietitian needs to be there every step of the way. And so we have screening, assessment, intervention, monitoring, and that is a cyclic process which goes on. So intervene, monitor, intervene again, and so forth and so forth.
So actually, if you use the mic, probably people sitting at the back will be able to, or you can use this.
No, he is audible, sir.
I am never not audible. So my question to you, Chandrakant. Right. So how would you screen? How would you advise to let's say a new doctor has joined, new junior doctor, it happens every day. Yeah.
So,
I see that happening in our place every day. There was a time when there was one new doctor every month, I think they've stabilized now a bit. Anyway, so how do you advise them? They ask you this question, sir, how am I going to screen my patient? What screening tool am I going to use?
I mean, just to answer that new doctor, ma'am, so it's a teamwork, So you showed so many people. So that's why we have so many doctors coming in, right?
But
So-
right now I don't have too many.
So we have an
choices.
MGT, so you have so many lists, so that's why we have so many doctors coming every time. We have 3 people coming in successively to take the rounds. So that was an vital note. So screening, So the moment I say screening, there is a big protocol of 8 parameters, of how to figure out in an OPD. You counsel the patient when how he is going to do or whether I will screen. So 2 important questions to ask the patient. Whether this patient is malnourished or not. Number 1, how is your appetite? Has it reduced than what was before? First question. Second question, is there any weight loss? If the answer is yes to either of them, then the patient probably is getting into malnutrition. And now, if the question is yes to either of the 2 questions, then we have multiple nutritional scales to screen, There's so many, there are so
That was the
many.
screening part. The first
Yeah.
one was the screening
Yes.
part, and now you're
And now we
assessing.
will assess. So as you said, screen, assess, intervene. So the second step is assessment. So assessment usually we do not do, but even we are supposed to do actually. So assessment is done by, we do what is called as a patient-generated subjective.
Subjective program. Yeah, so
Yeah.
that's a PG, SG here, right? So there are different assessment tools rather. What I feel the take home would be from this slide is that it is more important to actually screen and assess rather than nitpick about which tool you're going to use. So that's what I thought was more important to highlight here. Okay. So again, coming back to the guidelines. So how would you, Chandana, we can continue on this one. So screening and assessment.
So,
and, yeah.
So the moment I found the deficiency in the winter, and very importantly, as you said, exercise. We see what is the hand grip. Is he able to have an adequate hand grip? It's also important to assess sarcopenia. That means the nutrition is so severe that the muscles are broken down to generate calories. So I would need a calories of 30 kilocalories per kg per day. That is the target what I would want to attain. And 1 to 1.5 grams of protein per kg per day. So this is which is very difficult to attain. And the rest all is as per the RDA, the micronutrients. So I would try and attain this gradually and not immediately. And I would, as we were talking before, oral nutrition is preferred
Oral nutrition, yes.
than parenteral or unnecessary supplementation.
Just according to the guidelines are a free download. Anybody can go into it if you're interested in cancer nutrition. So first is, as Chandrakant has rightly put, to detect whether the patient does have a nutritional deficiency at an early stage, and to take all these parameters, and then if you have an abnormal screening, then you go for a sort of assessment of the patient's nutritional intake, etc., and the muscle mass and the physical performance. Also, the ECOG scoring may be would be important in deciding. And these energy and substrate requirements, as we were saying, we have these parameters at 25 to 30 kilocalorie per kg per day, up to 1 to 1.5 protein gram per kg per day protein, and the different vitamins and minerals. And if there's that would be for everybody. And if there's weight loss, then and insulin resistance, then you could probably shift to a more keto, a more fat-based diet rather than a carbohydrate-based diet. Right. So, if
And
you
one
look
thing
at
I
this-
want to
yes,
add-
Anurag.
Add is that whatever monitoring is done, that should be continued on a daily basis and recorded in the day-to-day chart so that one can easily
Right.
scan through.
Especially for admitted patients, dietitians come and actually record how much they've taken. How much has been given to them is not necessarily how much a patient. Sometimes the patient might be feeling nauseated that day and might refuse the whole meal. Absolutely, you're perfectly correct there. Okay, so Arnav, going to take this one, please. General concepts of treatment related to nutritional interventions and exercise. So, what sort of interventions would you advise? Would you advise exercise? When? How much?
So I will first see how is the patient's ECOG status. If the ECOG status is 0, 1 or 2, then I will add nutritional intervention along with exercise also. And if ECOG 3 or more, then probably physiotherapy will take into the action. ECOG 4, definitely no exercise. And regarding nutritional intervention, so first I will check how the patient's internal tract, if it is not obstruction, not paralytic areas of a bowel fistula, whatever is there, that entering feed is not tolerated, then we'll go for parenteral. Otherwise, enteral will prefer. And in enteral also, I will first check how is the patient's appetite. If the appetite is good, then we can advise, it is counseling as well as the nutritional modification. If the appetite is not good, then we have to interfere the appetite also with some pharmacologic intervention, the counseling, all will take into picture. And if enteral is not an option or if it is a limited efficacy, then we add the IV options also. And in there also, depending upon the patient's catheter, central line or peripheral interventions, or sometimes of that.
Right, thank you. So oral nutrition, among nutritional interventions, oral nutrition, if it is tolerated by the patient, then obviously oral. And medical nutrition therapy, if oral nutrition in the sense that whatever food the patient is taking. Medical nutrition therapy can be either enteral or parenteral, that is you're using the GI tract which is functioning, or you're not using, or the GI tract is not functioning, or it's not adequate. So we come to the concept of supplemental parenteral nutrition in a very short while. And then you add that. Right, and then as exercise, as Arnav has put it very well, depending on the patient's functional status, you decide how much exercise the patient is. But exercise is also good for nutrition, enhancement, right? So Anirbandha, can you take this one, please? So pharmaconutrients and pharmacology. So what additives to your diet would you advise? What medicines would you advise to these patients?
Very clearly, Shudakina, in this way I am very clear that we have evidences, but still we should not consider everything as a foolproof evidence. Evidence is sporadic, definitely we have. So in this case, we have to follow the concept that one size doesn't fit all, and whether the patient is having a GI malignancy or a non-GI malignancy. If non-GI malignancy, whether it is a bone tumor or soft tissue, or if it is related to some other system. So these are the primary determinants of choosing the pharmaconutrient or the pharmacological agent. But important point is that we have a selected list. We need to know whether this patient needs protein and whether this can come as a protein or in amino acid form, whether lipid and how much of it can be administered or is it safe. Number 3, what is the micronutrients, what are the existing deficiencies and how much needs to be covered in a single dose. So these, based upon this, we guide the pharmacotherapy and nutrients.
Thank you. So steroids are actually used by palliative physicians a lot in oncology patients, and it actually does help in these patients, but the rest of them are not so, not so very positive. Progesterones are advised, but the side effect is thromboembolism. What you could guidelines say N3 fatty acids and prokinetics, obviously. So these are the ones with good evidence. The rest is not so evidence rich. The evidence is still coming in. There's guidelines. They might change. So surgery. Sorry. Yes. So in your surgery patient, coming back to our index case actually. So that gentleman. So now he's come, now he's post chemotherapy, neoadjuvant chemotherapy, he's coming for surgery and post surgery. So how do you post surgery? How do you go with this nutrition? When would you, because see it's a GI surgery, the intensivist is not going to touch unless you say go.
So basically, the patient will.
So this patient will require a D2 radical gastrectomy, followed by Roux-en-Y anastomosis and a feeding jejunostomy. So usually on first 4 or 5 days, we usually don't allow orally. There's a light tube which is kept in as a decompression for the stomach. And we look at the amount whether the delayed gastric emptying is happening or not. Okay, so that is one thing. So we start the enteral feed by the feeding jejunostomy tube. Usually a low osmolar diet, and dietitian decides how much calorie and what to give. Usually high protein is there, and that has to be continued based on the body weight. Physical activity we start on the very first day. We try to get the patient out of the bed and if possible then mobilize. ERAS protocols has to be followed, means early taking out of the catheters, putting in less drain, although in upper GI, a lot of patients they say that don't put in drains, but we on the practical basis we put in drains, and that is there also for at least 7 to 9 days in a lot of patients. Only after they have taken oral soft diet and the drains are clear, patient is fasting motion, so after that only we use to take out the drains. But ERAS protocol definitely has to be followed. Anticoagulants, Clexane has to be started to prevent the DVTs, and early shift out from the ICUs. We want to de-escalate the antibiotics and everything, and try to put on the oral diet as and when we are comfortable that the anastomosis is healed, there is no stomach failure on the duodenum side, and then we can just start the oral nutrition slowly. Slowly in the form means we usually start with 30 ml per hour to begin with, after clamping the Ryle's tube, and just see whether the patient is vomiting or not. Gradually we increase the oral intake and reduce the feeding jejunostomy tube feeding. The fluids we try to stop within 3 to 4 days time, so that source of infections are reduced. And then when the patient is able to tolerate the soft diet with high protein, then it's adequate for us.
Right, thank you. So ERAS, as you rightly said, so ERAS is the way to go, and basically ERAS and patients at risk. So let's say this patient was, post chemotherapy. This patient lost a lot of weight and had to wait out a bit before he could actually, go for surgery. And when the patient came back to you, or maybe got lost to follow up for some time, or had complications of chemo, so there was a prolonged. Because a plan is something, but what actually happens on the ground is something a bit different with these sort of patients sometimes. So now this patient has lost a lot of weight and is malnutrition when he comes to you. So preoperatively.
Preoperative optimization is required. We usually like to operate on the after 3 weeks of neoadjuvant chemotherapy, last dose, and when the blood parameters are normal and the body is actually gained weight adequate amount. So what we advise just after the 1 week of post chemo is that you start walking at least 4 to 6 kilometers per day, and do incentive spirometry so that the lung functions is improved. Try to take as much orally as possible. If he is not able to take orally, then we usually means in a stomach patient, we usually make a feeding jejunostomy before starting a neoadjuvant chemotherapy. Is not tolerating orally, having dysphagia, so that the nutrition can be maintained. If all these measures are not helping us, then the role of parenteral nutrition comes in. Whether you have to build up the patient on a fast basis. Even preoperatively, but that's not means a norm. Usually a norm is to make a feeding jejunostomy and build up in that way. Parenteral nutrition, if the patient is not, if we are not able to give adequately because patient is having loose motions or having some other complications of chemotherapy, that we are not able to use the GI tract, then only we use the parenteral nutrition, otherwise not.
One thing I want to add, Sudakshina, here is, see, the patient may not improve in terms of weight loss. Even weight loss may further progress. So that is not an end point of our treatment. Only our thing is to improve the nutrition so that the deficiencies that are noted parametrically, that needs to be corrected. Because if we try to achieve a correction or prevent weight loss or gain, that we may not be able to achieve it by supplementing with it. Whatever our aim of supplementation is so that patient can tolerate, patient can withstand the complications which are likely to occur with the coming days. So I think that is very important.
Yes,
Actually, if the patient is not gaining weight and losing muscle mass, then there is a high risk of getting a post-operative anastomotic leaks. So we are not very much comfortable if the patient is not tolerating the chemotherapy.
Now the case has progressed. So
Yes.
let's say on your rejuvenant chemotherapy there was a sepsis episode, the patient had to go to ICU, stay there a few days.
So his performance status is not improving actually post-neoadjuvant chemotherapy.
That's right.
So your intent can be changed. Means actually after neoadjuvant chemotherapy, if the performance status is poor, then your intent changes.
Absolutely. So you might even need to change your plan for a plan. So that's an important thing for everybody. So we're talking about parenteral nutrition and supplemental parenteral nutrition. So your take on supplements, parental and Sunny's covered a bit of that, parenteral nutrition and.
Yes, understand. So parenteral nutrition has total parenteral nutrition and supplemental parenteral nutrition. Supplemental parenteral nutrition is being supplement to the oral nutrition. So oral nutrition is enhancing whatever diet he has. Enteral nutrition is putting a FJ or filling through a nasogastric tube. And then comes supplemental parenteral nutrition and then comes total parenteral nutrition. So these are the different steps we go ahead with. So in all means we would try and use the GIP unless it's not functional, or there is gross mucositis, or there is GI carrier infection. We would give oral or enteral nutrition whenever possible.
Or like Sunny said, if this patient has a gastric outlet obstruction, then food is obviously not going to pass. So the patient, even if there's appetite, the patient can take food, but the patient is not going to be able to be anabolic, or at least prevent the catabolism.
True. So of course we need to have a functional cut either by FJ or a palliative gastrojejunostomy if it is metastatic. So if he is not able to meet the requirement, let us say pre-op, we need to have a quick recovery. So in fact we can admit the patient, we do so because stomach is such an area where nutrition is very important. So we do admit the patient if the patient is not recovering post chemo. The surgeon says, I cannot operate now. You give more chemo or you optimize and send me back. Then of course we do admit the patient. We put a nasogastric tube and we have strict assessment of his
We
nutrition
actually assess
improvement.
the patient is beginning
Yes.
to gain or not
Yes.
losing at least, and then we can wait out period of it, and then we
So
go.
the moment patient is not improving after chemo, this patient is going to die. So this patient needs an immediate intervention nutritionally.
Thank you. So those were some thoughts on contraindications to EN, failed, inadequate, privileged GI function. We covered most of these, and some specific to surgical oncology patients. Post-surgery, there might be some complications, and that's why the prolonged diarrhea or bowel obstruction, fistula, a high output fistula, where the patient is losing more than the patient is actually taking. Right. So radiotherapy. Arnav, can you help us? This is also made of. So radiotherapy patients, any thoughts, nutrition in these?
So it will depend which area the radiation is being delivered. So suppose if it's a head neck cancer.
Actually, we were supposed to have a head neck surgeon on our panel, so I was unfortunately, yes.
So head and neck cancer, obviously nearly 100% patients will have very severe mucositis, and more than 50% patients will have the Ryan's tubes or nasogastric tube inserted. That period of time to overcome that treatment. Yes. And apart from that also, if somebody have the esophageal cancer or even the lower GI rectal cancer, so that time also patients might have very much loss of appetite. So that period also probably might need nasogastric tube or maybe intranutrition also if it is a grade 4 toxicity. Sometimes cervical cancer or prostate cancer also might have, but incidence are low.
Okay, thank you. So nutritional therapy, oral supplements, so screen and manage dysphagia, put in a tube, either a nasogastric tube or a PEG tube. So PN per se is not the first line. Try EN, it's the same protocol everywhere. Try EN, only EN fails, then only go for PN. Right. And medical oncology, so curative or palliative order again, I'll have to come to you.
So
these
both,
groups of patients, hematopoietic, I think we leave to Chandrakant.
so both curative and palliative patients, nutrition will have a very much definite role. Curative patients definitely during the course of the radiation, during the course of the treatment, as well as after treatment also, until and unless patient, we are very much satisfied that he has gained or at least in the correct path. And for palliative patients also, to improve the quality of life or at least to maintain some nutrition, at least maybe 80%, 90% if he or she can tolerate. So both we can give almost similar importance. And the routes are definitely already we have discussed, enteral, parenteral, cement.
And Chandrakant for high dose chemo
So,
and
yeah, so I'm going to 2 points for high dose chemo and transplant. Number one, parenteral nutrition has good evidence in this because the mucosa grows for a toss for several days. So parenteral nutrition is a definite role. And secondly, neutropenic diet. So we need to be following neutropenic diet at this time.
so that's about it. We've covered these. Yes, we've more or less covered all of the points. Right. So Onibanda. So we get a lot of palliative patients in our ICU sometimes, you know. Though it's a bit of a paradox, but in our country we still haven't actually moved away to the hospice care, and they often do end up in ICU. And though it's won't be the follow-up patients, cancer survivors, so it's not your area of expertise, but we just...
Yeah, that is true that we have seen cancer survivors when I was in Tata, when I worked in cancer and also at AIMS in IFC. This group, I should say that probably the nutrition management is comparatively easier in comparison to those patients who are in the active stage of the disease, and because they usually are only getting palliative chemo if at all, or no chemo, no radio, and in them probably simple regimes like a high fiber, high protein, a mix of essential and semi-essential. So these things are good enough to maintain a reasonable level of nutrition for the rest of their lives. So again, of course, there may be some specific needs and specific group of patients that we have to tailor. But overall, it's easier.
And the palliative.
So in palliative also the same thing applies because
For end of life, see,
this is a we need to consider the
feeding in an end of life situation.
Absolutely.
So,
So-
what's the current thing?
yeah. So in palliative situation also, that unless the patient is on some palliative chemo or palliative radiation, they escape those form of gastrointestinal complications that are attributable to the therapies. So they are primarily their gastrointestinal problem or nutrition is primarily of the disease per se. So therefore in them also, probably then those who are on active medication, from them in comparison to that section, these patients comparatively easier. We have to understand cancer cachexia, take care of the sarcopenia and give them a little bit of extra fat along with the protein, of course. We do maintain their status so that they don't develop that rapidly progressing multi-organ failure. So that's all we can
Anyone else would like to highlight on, palliative, end of life situations, nutrition? There was a very famous case in America where
So 2 things here.
I think
Yeah.
that was the name of the young girl, and there was a huge question about yanking out the feeding tube in that young girl.
So there is no point continuing parenteral nutrition in the dying patients. It has not improved outcomes. Ethical issues are important. We will not stop enteral feeds, but that is totally non-functioning patient is dying. There is not much benefit of EPN or excessive hydration. It is not benefited. I think it is totally.
Thank you. So that's about all. We've come to the end. So just our concluding slide, we've covered most of it. So screening, assessment, whether support is indicated, whether oral intake is possible, and what to do in those situations. So thank you. And in the end of life situation, so the patient's desires, the life expectancy of the patient and the performance stages should all be taken, especially the patient autonomy. So whether the patient actually, if you have an advanced directive, it's easier to make the decision. So thank you everybody. Thank you panelists very much.